Welcome to this educational video on the injection of lacrimal Botox for the treatment of epi4A. In this presentation, we will cover the clinical rationale, injection technique, safety consideration, and post-procedural care, offering a practical guide for ophthalmologists and oculoplastic surgeons. Epi4A or excessive tearing can be a challenging condition to manage, especially in patients with functional or non-obstructive etiologies. In such cases where anatomical obstruction is absent, botulinum toxin injection into the lacrimal gland has emerged as a minimally invasive and effective treatment option. The lacrimal gland receives parasympathetic innervation via the greater petrosal nerve, a branch of the facial nerve. Botulinum toxin works by blocking acetylcholine release at the neuromuscular junctions, thereby reducing glandular secretion. By inhibiting this parasympathetic stimulation, tear production can be significantly reduced, alleviating the symptoms of tearing. Ideal candidates for lacrimal Botox include those with functional epi4A, reflex tearing from dry eye, and certain cases of gustatory lacrimation. Key to successful outcomes is patient selection, excluding those with anatomical obstruction, and assessing tear film balance to avoid overtreatment. Dosing typically ranges from 2.5 to 5 international units of botulinum toxin A per gland. Lower doses are preferred initially, especially in patients with borderline dry eyes. The dose can be adjusted in follow-up treatments based on efficacy and side effect profile. Now let's walk through the injection technique. After ensuring informed consent and aseptic preparation, the patient is positioned in primary gaze. The upper eyelid is gently everted to expose the palpebral or lobe of the lacrimal gland. A 30-gauge needle is used to inject the toxin directly into the gland through the transconjunctival route, ideally 8 to 10 mm above the lateral canthus. Accurate localization is critical to take care to avoid adjacent structures such as levator palpebrae superioris and superior rectus, minimizing the risk of ptosis or diplopia. Although generally safe, complications still can occur. Transient ptosis may result from diffusion into the levator muscle, while diplopia can arise from envelopment of extraocular muscles. Dry eye symptoms may worsen in some patients, requiring lubricants or temporary cessation of therapy. These side effects are typically self-limiting and respond well to conservative management. Proper injection technique and careful dosing are the best means of prevention. Lacrimal Botox injection represents a valuable tool in the management of select cases of epi4A. With a sound understanding of the anatomy, mechanism of action, and potential risks, clinicians can confidently incorporate this technique into therapeutic arsenal. Thank you.